We'll take questions. We got about 15 minutes, and then it's the reception's going to start. So any questions?
Hi, I'm Steve Washburn. I'm an orthopedic surgeon in a rural area. Dr. Johnson, I wanted to know what your take was when you do you still do emergency room call?
I do no longer take emergency room call, though the small rural hospital with whom I have my active privileges does call me between 6 and 12 times a year. But when I opted out of my orthopedic group, I opted out a level 1 trauma call at the 2 big trauma hospitals.
And
so
that helped with your opting out, I assume.
Pardon?
That helped a lot with opting out.
It helped a lot.
Right. Do you do any inpatient surgery?
And I do no inpatient surgery.
Okay.
Noting the trend and where our positions are, my question to you is, do you worry as you get ready to enter into the Medicare age group? Do you worry about your access, how it's going to work? Do you have a plan? How are you going to market to your doctors as a patient? I'm just curious.
Yeah. If I understand the question, I'll be 58 in November. What's my plan for when I enter Medicare age? I will find someone to take the funds that I want to render to them for the care I wish to receive. I think by then more surgeons will be opted out. I don't have an immediate plan, to be patently honest, and trying to be a better steward of my own health in the advent of that.
I think
It's a good point. Excellent point.
And interestingly, I once had an attorney who worked for a managed care company ask me if I knew anyone who was third-party free, because that's who she wanted to see.
Yeah, I may relocate to Oklahoma City, where Keith Smith and some orthopedic buddies of mine have started some independent.
I think it's interesting. Also, we heard comments about this earlier today too, where I think the physicians that are the angriest about other physicians opting out are usually the ones who are so frustrated with the system that they don't see this as a viable option, and their anger or frustration is not directed at the physician who opts out. They're actually hoping that they can do it. And interestingly enough, also, and I, talking about the changing tide of even in the minds of physicians, I know it seems really strange for me to say this, but last night I actually moderated a panel discussion of the discussion was physician-hospital integration for the 21st century. I told my wife earlier in the week it was like I was going from the North Pole to the South Pole in 2 days. And I thought at first it was going to be kind of an uncomfortable setting for me, but they picked me to do that because they knew how differently I felt about that model. But interestingly, when we were talking about changing healthcare, especially in the state of Tennessee, where they have this new Tennessee Healthcare Innovations Initiative, when I asked the question about that and I started to prod a little bit, the chief medical officer for one of our large hospital systems actually spoke up and said, I believe initiatives like this are going to drive more physicians to opt out of Medicare, to opt out of the system, and if I wasn't in the position that I'm in right now, I would probably be looking at doing the same thing. So I don't see it changing. I think that more and more people are becoming accustomed to the fact that there's physicians out there that are doing this.
The Surgery Center of Oklahoma is certainly an excellent model of an ambulatory surgery facility, but we really need some hospitals that are not contracted with Medicare. I believe this is possible, and there may be some incentive to do it because the restrictions that the Affordable Care Act put on physician-owned facilities, I believe, are tied to the Medicare contract. This would enable the hospital to get out from under its EMTALA responsibilities, from a huge Medicare overhead, and to offer more affordable services. And I have heard that there are some hospitals that are doing this, but I don't know where they are or whether they exist. And if any of you know, I would like to find out about them or what you think about how to encourage this possibility.
I guess you don't have an answer. Dan, thanks for your talk. My name is George Christie. I'm a interventional cardiologist in Chicago. It's my first time with the organization, first meeting, and it's been an impressive afternoon. And leaving my practice to the hands of others today has been very much worthwhile. So thanks. My question to you is, listening to everybody speak, it seems like the way that you can do this is you have to almost separate yourself from the inpatient practice of, as a proceduralist myself who does, pacemakers and stents and ICDs and things like this. As a proceduralist, you almost, and 56% of my practice is Medicare, because who gets heart disease is the older folks. And I'm by myself, and I've left a group of 60 to go on my own because I like running my own show. Been able to be successful in terms of volume and busy and reputation and things like this, but how can somebody who's a single practice practitioner who takes care primarily of older people because of the disease that we take care of, how can you legitimately opt out of Medicare when you are so dependent upon a cath lab to do angiography, to do stenting procedures, whether it be coronary or peripheral, unlike Dr. Johnson, who's able to set up a surgery center within a building, elective work only. I don't take ER call either, which is but I also give up all the non-invasive reads that come in for the unassigned patients. I don't read echoes for unassigned patients. I don't read EKGs or stress tests. I do my own. I'm busy, but for not taking call, I took a hit from the hospital by not reading the things. But let me tell you, when you sleep at night because the ER is not calling you for the unassigned patients that don't pay you anyway. But how can a solo practitioner who is very much interested in, putting some order to the practice opt out of Medicare when 56-60% of your patients are Medicare, and you need the hospital? And the hospital I work at is not opting out of Medicare
Right.
to survive.
It's definitely that's definitely a tough one, but at the same time, just because you've opted out of Medicare doesn't mean the hospital's opted out of Medicare, and doesn't mean that those patients still can't get their benefits from Medicare for you being under a private contract with them for their procedure, but the hospital billing their Part A Medicare. You would not be able to file your Part B. They would have to enter into a direct contract with you.
Provided it's not an emergency or urgent basis.
Right. And, and any type of implants or anything like that would be covered also. There was talk earlier today about the fact that if you have an MPI number and if you have a PTAN number, opted out physicians actually in the state of Tennessee and under CAHABA, I don't know how some of the other Medicare administrator contracts work, but CAHABA actually on there, they actually have a form that they want you to fill out. And on that form, it actually says, are you going to be a referring physician? Or are you going to be an ordering physician, is what it says. And if you check yes, then they maintain what they consider an opted out PTAN, so that you can continue to order labs, x-rays, MRIs, anything that would normally be covered. If Dr. Gorman wanted to go to an ASC, they would cover the ASC cost. They would cover anesthesia, but he would have to have a private contract with the patient for the physician part of that service.
It's definitely going to be harder being more hospital based,
Right.
and I think it goes without saying that your complexion of your practice as a specialist, if you're an interventional cardiologist, GI doc, surgeon of any flavor, if in a dermatologist who does a lot of procedures, you're going to take a complexion change of your practice to do this. And it's inextricably linked to unattached call. For orthopods, it's unattached trauma call. It's not just group call, it's unattached trauma call. And again, regional carriers may differ. You may find that it's actually, I would sense most cardiac events are life-threatening. You may sense that that's not going to be too big of a hurdle to get reimbursed for that initial care, but it was a thrash for me.
It's great to be in this meeting because I'm attending this meeting of AAPS for the first time. I became a part of AAPS like 4 or 5 months ago, and I think that's a great organization, and it's great to see so many like-minded physicians, because I finished my residency like 2 years ago, and I see all this federal government control over physicians' practice and everything. I now knew that there was a forum like this, whereby we can address so many issues. This is probably not related to in a specialist thing, but I was just wondering, if I had known about this forum like AAPS when I was a resident, or even when I was a medical student, surely I would have been part of. I would have loved to be part of this group. Are we? And I saw a few medical students here before. I was just wondering whether, as a group, we are sort of engaging with residents as well as medical students to make this a little more visible organization.
Well, as I mentioned earlier too, we do have an educational foundation, and we welcome donations to that because that's largely how we fund being able to have medical students come to these annual meetings, for example, and residents. We recognize that they are the future, and we would like to recruit more medical students and residents.
And one exhortation for all of us that let medical students shadow in our offices, residents, don't let the opportunity slide without mentioning AAPS and the advantage that it is, and the very low, if any, cost it is for them to participate at that level.
Actually, I came to know about AAPS when I was sort of browsing about one of the presidential candidates, Rand Paul, because in one of his profile it says that he's part of the fringe group, AAPS. When the mainstream media says that it's a fringe group, then you better be part of it, because they are doing something right, So, but I didn't know about this, like even 4 or 5 months ago, So we need to get involved, the residents, and medical students, who probably be more open to AAMC and ACP, who don't really care about the physicians or the patients, So, yeah. So I'm glad to be part of this forum.
Well, I would like to second that too. Kevin Tadish, orthopedics again. I think one of the things that I'm looking at as an orthopedic surgeon is that, again, the long waits that are going to happen and only really get bad for Medicare are going to drive our system towards finding fee-for-service again and make it feasible. Because if we go to a Canadian system where the average wait is 5 years, starting at age 70, and then at age 75, you can't have a total joint anymore, there's a lot of customers. And I'm seeing in our area where my Medicare population has gone from 25% of my practice to now 70%. It's just killing me. It's not worth doing anymore. But the waits are piling up, and people are going to get anxious and motivated to, and a lot of them can pay for joint replacements. And one of the things I look at in that sense is anyone with a hearing aid is $3,000 per hearing aid, not covered by Medicare. And if you can, and most orthopedic surgeons get about $1,000 for a total joint, they're paying 3 times more for their hearing aid than they are a total joint to walk again. I think the demand is going to pile up, and we will see, maybe not today, but shortly in another year or two, as 11,000 baby boomers hit Medicare, we're going to see the demand, and it will, if it's not today, it certainly will be probably real soon. And I also want to thank you guys for the conference. It's great.
And of course, it was an orthopedic surgeon in Canada who took Canadian Medicare to the court system, complaining about how his patients suffered while waiting for months and months and months for hip replacements and other orthopedic surgery. and he argued his own case. He did have some legal training and ultimately won the ability, at least in Quebec, to privately treat patients. You know, there are only 3 places in the entire world where the practice of private medicine is illegal: North Korea, Cuba, and Canada. Let's take one last question.
Refresh my memory, hasn't the Mayo Clinic opted out of Part A Medicare? And what about Cleveland Clinic? I've heard that they did. I don't know for sure, but that would be interesting to know.
I think I think Cleveland Clinic had gone non-par with their radiology, like MRI, CAT scan, those types of things. But I don't think they opted out. But I don't know that for a fact.
Does anyone know about Mayo?
And I know Mayo, some of them did too.
So for those of you who are attending the reception and briefing and dinner this evening, be sure and take your speaker evaluation forms with you. We very much appreciate having all of you here today, and we hope that you learned something to take home back with you.